Hello, everyone. Thank you for attending this lecture. We have the pleasure. We have Professor Brian Ference, cardiologist and genetic epidemiologist from University of Cambridge at UK. And with a pleasure, he's going to present the time to prioritize cumulative exposure to LDL cholesterol. We're happy to have you.
Thank you very much for having me. It is a real honor and a pleasure to be speaking in the kingdom once again. And I look forward very much to the time when we can meet in person, because I think these kinds of lectures and opportunities to exchange ideas is really much more powerful in person. These are my disclosures. But I think we all share, a common vision for how we can reimagine precision population health with the goal of extending the healthy lifespan by much more effectively preventing cardiovascular disease. And really preventing cardiovascular disease and cardiometabolic disease more generally, to include diabetes and hypertension, really provides a unique opportunity to think about how we can reimagine prevention to be much more effective, because we know exactly what causes heart attack, stroke, hypertension, and diabetes, and how to prevent it. For example, we know that atherosclerosis is caused by the trapping of ApoB-containing lipoproteins within the artery wall. Hypertension is caused by the progressive injury to the artery wall, resulting in increasing blood pressure with age. And diabetes is caused by the increasing dysglycemia caused by weight gain. But what's important to recognize is that each of these causes of disease is modifiable. Even more importantly, each of these causes of disease builds up slowly throughout life, well before someone's diagnosed with a heart attack or stroke or hypertension or diabetes, which means we should be able to identify people early in the course of disease and intervene to dramatically reduce their lifetime risk of cardiovascular disease. And this vision provides us with an organizing principle that suggests the most effective way that we can maintain cardiovascular health is to prevent the development of atherosclerotic cardiovascular disease by minimizing cumulative exposure to lifetime exposure to the cause of atherosclerosis, which is LDL, as well as minimizing that cumulative exposure to those other modifiable causes of accumulating injury, irreversible structural injury to the artery wall, which are diabetes, hypertension, and smoking. But as we think about how to much more effectively prevent cardiovascular disease, we have to start with LDL, because LDL is not merely a risk factor. LDL is the cause of atherosclerotic cardiovascular disease. As all of you know, all LDL and other ApoB-containing lipoproteins less than 70 nanometers in diameter can freely flux across the endothelial barrier. And while the vast majority of these particles are returned to the circulation by the lymph system, occasionally one of these particles will become trapped within the artery wall. And it is this trapping of an ApoB-containing lipoprotein within the artery wall and the subsequent presentation of its cholesterol content to macrophages that it initiates a cascade of inflammatory events that is the necessary step for both the initiation and the progression of atherosclerosis. As more particles are trapped in the artery wall, the plaque slowly builds up over time, and the corresponding risk of cardiovascular disease increases. This simple and intuitive understanding of the underlying biology of atherosclerotic cardiovascular disease leads to the cumulative exposure hypothesis, which suggests that our overall plaque burden is directly proportional to our cumulative exposure to LDL, which in turn determines how many particles we trap within our artery wall. And this cumulative exposure hypothesis really explains how and why risk changes over our lifetime. Early in adulthood, as particles become trapped within the artery wall and the plaque slowly grows, the risk of having an acute cardiovascular event like a heart attack or stroke is very low. And the reason for that is that because as the plaque is growing early in life, the underlying plaque burden is too small, so that even if the plaque did disrupt, the overlying thrombus would not be large enough to occlude the vessel. And therefore the risk of having an acute heart attack or stroke is quite low. However, once we reach a certain cumulative threshold of exposure to LDL and trap enough ApoB-containing lipoproteins within the artery wall, the plaque burden is now large enough so that if it did disrupt, the thrombus overlying the disrupted plaque could potentially occlude the vessel, resulting in an acute coronary syndrome. And as more particles become trapped within the artery wall and the plaque continues to grow beyond this point, the risk of having a heart attack or stroke rapidly increases with age, which explains why the risk of cardiovascular disease only appears to be directly related to age, where age is merely a measure of our cumulative exposure to the causes of atherosclerosis. Now, what's important to recognize is that this cumulative threshold burden will depend, if it will be different for each person, depending on where they are in the world, or whether or not they have hypertension or smoke or diabetes. And in particular, in the kingdom, where the mean age of a first MI is 43 for men and 48 for women, this threshold is probably low. But the major implication of the cumulative exposure hypothesis, however, is that we can dramatically potentially reduce the lifetime risk of cardiovascular disease by lowering cumulative exposure to LDL beginning early in life to change the trajectory of atherosclerosis and slow the rate at which particles become trapped within the artery wall, to therefore delay the age at which we developed a large enough underlying plaque burden that we're at risk for having a cardiovascular event. And indeed, it's been estimated that lowering our LDL by just a millimole can reduce the average age of having a heart attack in the West from age 64 to age 100 by slowing the plaque burden. And it turns out there's a great deal of evidence to support this cumulative exposure hypothesis. For example, a recent study of 25,000 persons in Sweden, both men and women, who underwent coronary CT angiography, demonstrated that both men and women develop atherosclerosis in exactly the same distribution, but the plaque develops roughly a decade later in women than in men. But perhaps even more interesting than what these data suggested was that by the age of 40, about 20% of men have detectable level of plaque within their arteries and coronary CTA. By age 50, a third of men have plaque, and by age 60, 2/3 of men have evidence of plaque in their artery walls, just clearly providing direct evidence for the cumulative exposure hypothesis, suggesting that the more particles we trap in our artery walls, the more our plaque slowly grows over time. But perhaps the most compelling evidence for the cumulative exposure hypothesis and the potential to dramatically reduce the lifetime risk of cardiovascular disease comes from nature. We know that people who are randomly allocated to inheriting a specific genetic variant or combination of variants that are associated with lower lifetime exposure to LDL have a corresponding log linear reduction in the lifetime risk of cardiovascular events. And this log linear relationship between the lifetime exposure to lower LDL and the corresponding lower lifetime risk of cardiovascular events is quite similar to the log linear relationship we see between the absolute magnitude of LDL reduction in trials and the corresponding proportional reduction in risk. The difference, of course, is the slope. Each millimole or milligram per deciliter of LDL over the long term is associated with a 2- or 3-fold greater reduction of the lifetime risk of cardiovascular events as compared to the same reduction in LDL started later in life with a statin observed in randomized trials after atherosclerosis developed. These data provide direct evidence that LDL not only causes atherosclerosis, but that it has a cumulative effect over time. Indeed, the European Atherosclerosis Society recently summarized the totality of the evidence that included data from more than 200 studies involving more than 2 million persons with 20 million person years of follow-up and 200,000 cardiovascular events. And they showed that there was a clear log linear relationship between increasingly lower LDL and the corresponding lower risk of cardiovascular disease, and that benefit increased with increasing duration of time. Indeed, it is clear that all of the current clinical practice guidelines around the world implicitly endorse this notion of the cumulative exposure hypothesis, because they all explicitly suggest that persons who have familial hypercholesterolemia or LDL above 5 millimoles or 190 milligrams per deciliter, LDLs in the FH range, should be screened for and treated as early as possible in order to minimize their lifetime risk of cardiovascular events, because they have such a prohibitively high lifetime risk of cardiovascular events. And this is particularly important for the kingdom, where the prevalence of FH levels of LDL is 2 or 3 times higher than it is in many other parts of the world. And the naturally randomized evidence would strongly endorse this recommendation, suggesting that if we were able to, if persons who had LDLs above 5 or 190 milligrams per deciliter could reduce their lifetime exposure to LDL by 1/2, they could reduce their corresponding lifetime risk of cardiovascular events by 80 or 90%. But the data also suggests that this threshold of 5 millimoles or 190 milligrams is arbitrary. All of us could reduce our lifetime risk of cardiovascular events by 2/3 or more if we simply lowered our LDL by half. And indeed, it's been estimated that if there was a simple and convenient way to reduce our LDL by half, we could make cardiovascular events rare. And those persons who would benefit most are those persons who would have the highest LDL levels, because they would achieve the greatest absolute reductions in LDL and the greatest corresponding reductions in the lifetime risk of cardiovascular events. However, it's important to emphasize that the cumulative exposure hypothesis does not focus exclusively on LDL. LDL is the cause of atherosclerosis, and the number of particles we trap in our artery wall determines the size of our plaque burden. And our plaque burden, in turn, is the biggest risk determinant of our risk of cardiovascular events. But at any level of plaque burden, the risk of having an acute coronary syndrome like a heart attack or stroke is independently increased by exposure to other causes of irreversible injury to the artery wall, including dysglycemia of diabetes, smoking, and diabetes. Indeed, the naturally randomized evidence suggests that LDL and blood pressure have independent, additive, causal, and cumulative effects on the lifetime risk of cardiovascular disease, such that maintaining modest reductions of 1 millimole lower LDL and 10 points lower blood pressure over the long term could reduce our lifetime risk of cardiovascular events by 80%, reduce cardiovascular mortality by 2/3, and reduce overall mortality by 1/3. And this is particularly important among persons with diabetes, which is a very important problem within the kingdom. The kingdom has two high levels of LDL levels and a high prevalence of diabetes. It turns out that at any level of LDL level, and therefore cumulative plaque burden, the risk of having a heart attack or stroke is 2 or 3 times higher in diabetes. And that provides us with an opportunity to be even more aggressive and really dramatically lower our LDL among persons who have diabetes, because the dysglycemia of diabetes causes negative remodeling, resulting in long, thin arteries that cannot accommodate plaque in the artery wall, and therefore cannot undergo positive remodeling. Instead, persons with diabetes trap all of their plaque within the artery, narrowing that, reducing the narrow lumen, making it more likely that any disrupted plaque is more likely to occlude the vessel, thus explaining why persons with diabetes have a 2 or 3-fold greater risk at the same level of LDL and plaque burden. But what the data suggests that if we lower our LDL by a millimole over the long term, we can essentially eliminate that extra risk caused by diabetes. So it is particularly important to not simply focus on LDL, but also to prevent or reverse diabetes. Now, importantly, despite this intuitive understanding of the biology of atherosclerosis and the potential to dramatically reduce our lifetime risk, we still don't have the tools at the moment, or at least haven't had tools that effectively incorporate causal effects or reflect the underlying biology of atherosclerosis or the cumulative effects over time. Until now. Soon this summer will be released at the European Society of Cardiologists in the late-breaking Hotline trial, a new suite of causal AI algorithms that incorporate the causal effects of LDL and blood pressure and diabetes and smoking into risk and benefit estimating engines that can predict precisely what our lifetime risk of having a heart attack or stroke is over any follow-up, or with any over the whole of our lifetime, and precisely predict the benefit of lowering LDL during each month of follow-up in randomized trials. Therefore, if these causal AI algorithms can precisely predict both the risk and the benefit of lower LDL over our lifetimes and the benefit during each month of follow-up, it should be able to precisely predict the risk of having lowering LDL over any time in between. And when we conduct these experiments, what we see is that each decade earlier we start to lower LDL, there's a correspondingly greater reduction in the lifetime risk of cardiovascular events. But on the slide, the panel on the right-hand side of the screen is perhaps even more important. It suggests that if we lowered our LDL by just 1/3, roughly a millimole or so, beginning at age 40, as compared to being much more aggressive with twice a year inclisiran, for example, to lower LDL by 50% with a statin or inclisiran, we would have a lower lifetime risk of cardiovascular events at every age with more modest sustained reductions. These data confirm that long-term sustained modest reductions in the lifetime risk, lifetime exposure to the causes of atherosclerosis is much more effective at reducing the lifetime risk of cardiovascular events than more aggressive reductions in LDL starting later in life, even well before the guidelines start. But this slide also shows us something important about novel about biology. It suggests that regardless that the residual risk of having an acute cardiovascular event is due entirely to the accumulated plaque burden that develops before we begin to lower LDL. So that even if we reduced our LDL to zero, beginning late in life, we still have an underlying plaque burden that can disrupt and produce an acute coronary syndrome, thus accounting for residual risk. Now, importantly, this new suite of causal AI platform of tools will be able to solve the prevention paradox, because it will not only be able to precisely tell us exactly what our remaining lifetime risk of heart attack or stroke or hypertension or diabetes is, but it will allow us to choose a common lifetime risk goal and then titrate each person by recommending how much each person has to lower their LDL or their blood pressure in order to achieve that goal. Thus solving the prevention paradox by titrating each person to choosing the correct medicine for the right patient for the right time at the right dose. Now, even if we were able to do all that, and we're able to do that now, we still wouldn't be able to solve the most important problem. And that is, how do we get people to adhere to medicines? If we really want to think about reducing lifetime exposure to the causes of disease to transform and dramatically reduce risk, how can we possibly invite people to take a medicine every day? And that's where the transformational nature of the siRNAs like inclisiran directed against PCSK9 occur. It's not so much that these medicines are so powerful or so safe, it's that they provide a convenient way to powerfully reduce LDL that ensures compliance. And that is by itself potentially transformational. Indeed, but to have a therapy that we want to recommend early, it has to be safe. And the siRNAs like inclisiran directed against PCSK9 are very safe because they're designed to recapitulate the naturally occurring genetic variants in the PCSK9 gene that are associated with a lower lifetime exposure to LDL and a corresponding lower lifetime risk of cardiovascular events without any side effects. But inclisiran is designed to even be safer because it attaches to the small segment of RNA at GalNAc moiety, which means it's only expressed in the liver, and therefore should be even safer than partial loss of function variants in the PCSK9 gene. And if we look at the preliminary data from inclisiran in the Orion's 9, 10, 11 trials, what we see that they have remarkably potent effects, not just among persons with atherosclerotic cardiovascular disease or those at high risk of atherosclerotic disease, but even among those persons who have heterozygous familial hypercholesterolemia. What these data implies that lowering LDL by inhibiting PCSK9 with inclisiran, or the small interfering RNA, can dramatically reduce LDL levels in a sustained way that ensures compliance by 50% in anybody who has even partially functioning LDL receptors. And that's extraordinarily important in the kingdom where, once again, the prevalence of familial hypercholesterolemia is 2 or 3 times higher than many other places in the world. And it's important that we begin to seriously consider that reducing cumulative exposure to the causes of disease over time to more effectively prevent disease, because at the moment, we wait until it's too late. All current guidelines at the moment focus on informing the decision to start a treatment to lower LDL and titrating the intensity of that treatment based on short-term risk. But because atherosclerotic cardiovascular events only occur after atherosclerosis develops, focusing on short-term risk has the practical effect of inviting us to wait until a person develops a severe underlying mature atherosclerotic plaque burden before we begin to lower their LDL in order to reduce the risk of cardiovascular events. And that means we're waiting for people to develop atherosclerosis and only treating high-risk persons. In fact, in the guidelines, we define very high-risk persons as those persons who have documented atherosclerotic cardiovascular disease, either previous cardiovascular event or unequivocal evidence of imaging in 2 or more contiguous epicardials on a coronary imaging study. Therefore, we're treating people with mature underlying plaque burden. And for that reason, we have to dramatically lower LDL to extraordinarily low levels of less than 1.4 millimoles or 55 milligrams per deciliter, because the person has already a mature underlying plaque burden, and we have to get LDL as low as possible in order to prevent any further progression of that plaque burden and a really high risk of cardiovascular events. And that's extraordinarily important, once again, for the kingdom, where the median age of the first event is 43 in men and 48 or 49 in women, where we're inviting people to take medicines the rest of their life to prevent further acute cardiovascular events. And in particular, there are three groups of persons that are really high risk. Those that have had recurrent MIs, who've declared themselves to have not only mature atherosclerosis, but active atherosclerotic plaque, those that have multivessel disease, and those that have type 2 diabetes, all of whom have a 4 to 5% absolute risk of having an acute cardiovascular event every single year. So that after 10 years, they have a 40 or 50% risk of having an event, which creates a great deal of urgency to dramatically reduce their LDL levels to extremely low levels. As an alternative and in conclusion, we can be much more clever and effective about preventing cardiovascular disease, because we know atherosclerosis is caused by the trapping of LDL and other ApoB-containing lipoproteins within the artery wall. And it's the number of cumulative exposure and the number of particles we trap that determines our plaque burden, which in turn is the strongest predictor of having a cardiovascular event. It's clear that LDL has both a causal and a cumulative effect on the risk of atherosclerotic cardiovascular disease, and therefore, reducing cumulative exposure to LDL has the potential to dramatically reduce the lifetime risk of cardiovascular disease. But it's important not to focus just on LDL, but also to focus on reducing cumulative exposure to those other modifiable causes of irreversible accumulating injury to the artery wall, which independently increase the risk of having a cardiovascular event at every plaque burden and every cumulative exposure. If we don't do this, then we'll be left once again with just identifying those people who've had a cardiovascular event or who have very high risk of cardiovascular disease and be forced to lower their LDLs to extraordinarily low levels in order to protect their arteries. So with that, I'll stop and thank you for your attention. And I think we have a question session at the end. So thank you very much for your attention.
Thank you very much, Professor. That was really an outstanding talk. I bet there's a lot of questions from my side and from the audience, and we'll leave it for the end. We'll move on to the next talk. Dr. Suleiman Al-Kharabsha is from a cardiology consultant from King Faisal Specialized Hospital and Research Center. And we're very happy to have him here to give us a talk about the future trends in LDL cholesterol lowering and what's coming up. The floor is yours.
Thank you, Ali. Thank you very much. And good evening, everybody. And actually, Dr. Ferenc has, sort of set the stage now and for this new, I'll call it a new notion of this, chronic or lifetime exposure of the LDL. And I think this will be the new trend toward, treating people earlier rather than later and waiting for an event, trying to reduce the cardiovascular events, the number one or the leading cause of death in the world. As you see here, statins started, in the early 80s, and then the sort of combination or dual inhibition was sort of advocated, trying to reduce, the LDL, and with the good results. But however, as we see here, the patients usually, the patients and the physician have some challenges. One of the most important of which is the poor adherence, intolerance to medications, and insufficient response to therapies. And we know that from the statins, that almost over half of those who had MI, we're not talking about primary prevention here, it's a secondary prevention, high risk. They have poor adherence or non-adherent to their therapy. And again, we know from the, the slide or the same slide on the right side that if you're not adherent to your therapy more than 80%, your event rates will be much higher. So you have to be careful. And regardless whether you're following in a cardiology practice, unfortunately, or non-cardiology, less than 50% were achieving their recommended goal for those patients. So we've been looking for different options for, the LDL or cholesterol therapy. And now we have a few added to our armamentarium, and we'll talk about the few that are in the process. The PCSK9 inhibitors you're very familiar with, and the omega-3, sort of treatment, the Vascepa, we'll talk about it briefly. We all know about the PCSK9 protein, which is synthesized in the liver, and when it binds the LDL receptor complex, it will cause endocytosis and degradation of all. We know that from this is Dr. Ferentz's field, which is the natural experiment, people with loss of function of that PCSK9, though they have a modest reduction in their LDL, as you see, normal people is around 138, those people usually it's around 100, but because of the cumulative lifelong exposure, they have an 88% reduction in coronary heart disease events. Very impressive. This is a natural experiment. And again, monoclonal antibodies has been developed for this protein. And when you inhibit it, then the LDL receptor will be recircled. So you will have a more LDL receptor expression on the hepatocyte. Two studies has looked at this, which one for the evolocumab and the other one for aliricumab, the 4-year study. Again, we don't need to go the detail. Patients, and this patient, again, patients with established cardiovascular disease, if they're on maximum tolerated statin plus minus ezetimibe and they're not at their LDL goal, as you see here, 70, they were given either evolocumab or placebo. Again, primary endpoint is the typical MACE for the cardiology, and safety is the adverse cardiac events. We know that the drugs, cause around 60% reduction on top of course, previous therapy of the LDL, and this will be maintained all through therapy with a 15% reduction in event rates with a highly significant p-value, no doubt about that. And again, when you looked at different sort of events, the cardiovascular, basically, the main driver was the reduction of the MI. As Dr. Ferens showed that, we're talking about a short follow-ups now, 2 or 3 years versus a lifelong follow-ups. If you give, then the curves will continue likely to diverge and you will see more significant reduction in the mortality and others. Again, if you look at the different events, everything is favoring the lipid, the evolocumab therapy clearly from the trialist, the cholesterol treatment trialist, meta-analysis clearly shown here. Again, and this, now we push the limits, as you see here, the LDL reduction to even below 20. And it showed 2 things. One is the notion of that lower is better. Look at the adjusted hazard ratio. It continued to go down with the reduction of the LDL, and the safety that it's safe to reduce LDL below, the levels which we used to fear before, 70, 50, and now even we're saying even below 20, it was safe. The Odyssey is tested another PCSK9 inhibitor, which is aliricumab, and now it's in higher risk population, which is people with post-acute coronary syndrome, and this is even higher. The same inclusion criteria. Remember with the evolocumab, with the aliricumab again. This is a much higher group. Again, same reduction in the LDL and the same 15% reduction in, the absolute, in the relative risk ratio with almost 2% absolute reduction in the event rates. Very much similar to the evolocumab, no doubt about it. What about triglycerides? We talk about the residual risk. Those drugs has been reducing the event rates, but still the patient has a significant residual risk, what we call it, or event rates. And this has been explained very elegantly by Dr. Ferens, because those patients has been exposed. They already have a plaque can rupture, even if you're treating it or preventing further plaques. But triglycerides has been looked at before, and we know that elevated triglycerides increases the risk of both cardiovascular and strokes. However, we think that the heterogeneity of triglyceride is by the cholesterol contained in those particles or ApoB particles. And randomized trials has been showing inconsistent results, but we know that we treat very high triglycerides, let's call it more than 500, to prevent pancreatitis. The icosapentael ethyl is a highly purified EPA, which is being used for the treatment of triglycerides. And in this trial, the reduced trial, they looked at those patients who were maximally treated with a statin, and still they have more than 150 milligrams per deciliter triglycerides, either established coronary vascular or cardiovascular disease or diabetes with 2 or more additional risk factors. And it showed significantly reduction in cardiovascular risk by 20%, MI, whether it's fatal, non-fatal, 31%, and stroke by almost 28%. Again, there were a lot of, sort of criticism about the trial, but at least we're seeing that there is something that can reduce this residual risk. What about the bempedoic acid? This is a new drug, actually. It works in the same path or pathway for the cholesterol synthesis, and it's one of the rate-limiting enzymes in the cholesterol synthesis. Remember, the HMG-CoA reductase, which is the target of statin, is down here, and this is here actually in the conversion of citrate to acetyl-CoA. It's the enzyme called ATP citrate lyase. The bempedoic acid is an inhibitor of this enzyme, and it has a weak inhibition of the HMG-CoA reductase. And at the end, it will lead to reduction in the intracellular cholesterol with more expression of the LDL receptor. So still, the drug works through the increased expression of LDL receptors. Again, it has a very good high bioavailability due to its small molecular size and rapid intestinal absorption. However, it uses a different receptor in the hepatocyte to enter the cell. So it does not compete with the statin. So you could give it with the statin and it will give added effect also. It's a prodrug, so it has to be activated by an enzyme, which is, as you see here, a long-chain acyl-CoA synthetase 1. And this is predominantly expressed in the hepatocyte. It's much less expressed in the kidney skeletal muscle of the humans. And this is one of the explanations why this drug, when it's given, it has less myopathic effect or muscle symptoms that is usually attributed to statin. So as you see here, it gets activated in the liver. So main cells are the liver, not the smooth muscle cells or the kidney. And it has a longer half-life, as you see. So it's given once a day. A drug was given usually or tested at 180 milligrams once daily. And when it's given solo, it reduces the LDL by almost 27%. When you combine it with ezetimibe, the reduction is much more robust, around 48%. As I mentioned earlier, lower incidence of myopathy, and this is because the drug works only in the cell where it gets activated because it's product, which is the hepatocyte, not the myocyte. Again, the clear trials in both phase 1 and phase 2 has shown that the drug, as I mentioned, works very well by reducing LDL when it's given as solo or in combination. It does reduce the high sensitivity CRP by almost 30%. And it has no effect on the weight, as you see, and actually it has a neutral effect or even positive effect on the blood glucose to those patients who were treated, even on top of statin. And now the clear outcome trial is ongoing, so that we will look at the long-term, cardiovascular event and safety. It does increase the uric acid by almost 7.7%, as you see here, compared to the placebo. The lometabide and mipomycin are two orphan drugs. Orphan drugs, that means they're the only in class that has been developed for the treatment of homozygous familial hypercholesteremia. The drug works in a different mechanism now, not on the LDL receptor mechanism. So it has it's not affected whether you have a mutation in the LDL receptors. Mipomycin, as you see, is an antisense oligonucleotide targeting the ApoB messenger RNA. So it prevents the synthesis of ApoB. Lometabide is an inhibitor of the microsomal triglyceride transferase, MTP. And both drugs are very expensive with very much relevant adverse events. So the mipomycin, as you see here, it has shown in trials to reduce the LDL cholesterol by around 25%. However, because of the safety concern over the liver enzyme elevation and hepatic steatosis, the use has been very much limited to a program called Risk Evaluation and Mitigation Strategy, REMS, in the United States, and it's used only in certain, places, or it has to be dispensed through that program. The lometabide has shown to reduce the LDL by a little bit more robust, around 45%. And as you see here, based on the mechanism of action, it's used usually in conjunction with low diet and other lipid-lowering treatments. A modeling analysis suggests if the patient is using lometabide starting early at around age 18, it will increase the life expectancy by 11 years and the first MACE by almost, delay the first MACE by almost 6 years. Gastrointestinal side effects and hepatic fat accumulation, but still we don't know the clinical significance of that. The lower registry is evaluating the long-term safety and efficacy of this drug. Now, the newer targets, one of the most provocative ones is the angiopoietin-like 3 protein. This is a protein that is synthesized by the liver. When it's released in the bloodstream, it inhibits both the lipoprotein lipase in the vasculature and the endothelial lipase, which works on the high-density lipoprotein. And we know from, again, this is Dr. Ferentz's field, the genome-wide association that patients carrying loss of function of the mutation in the angiopoietin-like 3, they exhibit a syndrome called familial combined hypolipemia with low triglycerides, low HDL, and low LDL cholesterol. However, in those families or those groups, they have a 41% predicted reduction in the risk of coronary artery disease. So we have been looking at targets to inhibit it. And again, two basically drugs. One is an antisense oligonucleotide, and the other one is a monoclonal antibody, which is the new basically field. And this is evinacumab, is a fully human monoclonal antibody that has been developed to inhibit this angiopoietin-like 3 protein. And this has been tested in patients with homozygous familial hypercholesteremia, as you see here, a monthly injection of the drug on top, of course, the statin or high-intensity statin, ezetimibe, PCSK9, as you see in 77%, lumitabide in a quarter, and apheresis in 34%. And again, it has shown to reduce the LDL by around 50% on top of all that therapy in a mechanism that's in or different than LDL receptor or not LDL receptor dependent. And again, if you would look at the LDL reduction, ApoB reduction, non-HDL, total cholesterol, HDL, and more impressive is triglycerides, almost 55% reduction. So this is one of the new targets, which has shown to be very promising. Now, what about the problem? What are the unmet needs or treatments? Dr. Ference again mentioned that, or he has shown that the problem is that we have been pushing the limits lower now in the newer guidelines based on evidence, of course. With the 2019 guideline, as you see, you wanted lower targets. Only 18% are achieving that goal. So we really need something better, too. And the main issue is the patient persistence on therapy. Even with the PCSK9 given every 2 weeks, as you see, half of them will interrupt the treatment for over almost 30 days. And almost 44 will interrupt all treatment, unfortunately. So still, even if the drug has been given every 2 weeks, still it's not good for them. So as you see, the persistent on statin, 197 days basically, of therapy, ezetimibe 184, and even PCSK9 still 1/3 of the year the people are not taking it. So it's a problem. We need a drug that can be given less frequent apparently and under observed therapy. Inclisiran is one of these novel therapies that we talked about. Inclisiran works through the same mechanism like PCSK9. However, now we're inhibiting the synthesis of the PCSK9 protein through this small interfering RNA, which is really, as I mentioned, mimics the interference, the natural interference in the body. Again, this slide has been shown just to show you that this the inclisiran molecule is usually conjugated to this GalNAc to enhance its endocytosis. When it's inside the cell, this will be degraded from the GalNAc, which will be degraded, and release of the 2 strands, which will bind the RISC, what we call, toward the RNA-induced silencing complex that will split the passenger strand from the guided strand, and it will guide that strand to the messenger RNA encoding for PCSK9. It will bind it, leads to its degradation, so no synthesis of PCSK9. So no entrance to the nucleus, nothing, it will not affect the genetics. It only inhibits that protein synthesis from this messenger RNA. And again, it's the first in class, as you see here. It mimics the body process of RNA interference, and Because of the chemical modification and mode of action, it then provides an effective LDL lowering that is sustained over the course of therapy. Now we're talking about giving a drug twice a year rather than twice a month. Again, the Orion trials, Dr. Ferenc mentioned some of that, looked at for this Orion 9 was for people with familial heterozygous on top of high intensity statin ezetimibe. And as you see here, monoclonal against the PCSK9. This drug is given, as you see, the first on day 1, then day 90, then after that, every 6 months. And again, the goal of the aim of this trial to look at the reduction. Here, we started with an LDL baseline of 150, 155, and again, 50% consistent reduction in LDL, quite impressive. Again, regardless of the mutation in the LDL receptor, it does work. And the Orion 10 now looked at people with high risk atherosclerosis, already people with atherosclerotic cardiovascular disease who are not achieving target. Again, the same protocol, we don't need to waste time on it. And here they looked at the primary endpoint of the LDL reduction versus placebo, some secondary endpoint, and the most important is the exploratory, the cardiovascular events. Again, a little bit bigger trial than the Orion 10. And here I want to just you to see that now it started with a cholesterol or LDL cholesterol of 105, not 155. Again, almost 58% reduction, which is persistent or maintained through the trial. Again, looking at also the reduction in the PCSK9, total cholesterol, non-HDL, ApoB or LB(a), all were reduced according to that. And when you look at this forest plot, again, regardless of the, the sex, age, body mass index, and even here looking at the baseline cholesterol, atherosclerotic cardiovascular disease or not, inclisiran did better than placebo. The pooled analysis looked at safety, and again, other than just the site reaction, really no significant or sign of, liver, kidney, or hematological problem compared to placebo. And when we looked at this exploratory endpoint now, again, there was a trend toward the reduction. Remember, these are smaller trials, and this is an exploratory endpoint, but we will have more data in the future about this. But it was showing also a reduction in this pre-specified endpoint. Again, just showing what Dr. Ferenc has shown before. Now the guidelines are pushing the limits, and all those people who will have an event on this maximal therapy, they're saying now go less than even 1 millimole or less than 40. So you really need to use, the whole weapons in your armamentarium trying to get that or achieve that. As I mentioned, it's not easy as we think. And again, the future perspective has already been talking about, the PCSK9 and the small interfering RNA now in it. I think this is my last slide. Thank you very much. We'll stop here.
Thank you very much, Dr. Kharabsha. That was really you summed up the clinical data in a very comprehensive manner. Well, let's see if there's any questions from the audience. If you have any questions, please post it in the Q&A, and we're going to address both colleagues those questions. Well, I have my own question. I'm going to ask a very hard question for both of you. Professor Ferenc, if you are tasked to be the Secretary of State for Health and Social Care at UK, what would you do to manage a lifetime LDL burden for as a population cohort? And the same goes for the Dr. Kharabsha, the same question going to go. If you're the Ministry of Health, what do we do to really manage lifetime LDL burden for the population?
Yeah, that's a great question. And actually, it has been addressed by Novartis in the UK. Novartis negotiated with the National Health Service in the UK a reduced price for inclisiran for specific indications. Persons who had atherosclerotic cardiovascular disease and didn't make target, or those persons with either homozygous or heterozygous familial hypercholesterolemia. They then made that medicine available, and the goal was to give it to 300,000 persons to prevent a large number of future MRs. Unfortunately, it hasn't been taken up. And that's a really important lesson for population health going forward. The reason why it hasn't been utilized very much at all is because the and National Health Service really didn't have anybody who took responsibility for it. So as we think about whether or not we can give these medicines to people going forward, we're going to have to recruit a group of cardiologists or general practitioners or other physicians who want to prescribe it, identify exactly who's eligible, and then refer them into that network, almost like a trial, in order to get the medicine and then enroll them onto a platform where you can sort of watch them over time, manage their other risk factors aggressively, as well as ensure that they continue to get their 6 monthly doses of medicines over time to make sure they're adherent to, that they're hitting their LDL goals, and that their other risk factors are also being managed. And doing that in sort of almost like a quasi-randomized trial network appears to be beginning to make a lot of progress in England. But more importantly, I think, to answer your question more directly, for other places around the world, the only way to reduce cumulative exposure to LDL, to dramatically reduce our lifetime risk of cardiovascular disease, is to do two things. First, we can't give it to everybody. So we have to identify precisely who's at risk. And tools are now becoming available. But secondly, that's not enough. We then have to enroll them onto a platform where we can sort of give them information, measure their LDLs over time, learn their individual trajectories of LDL, reincorporate that information to personalized risks and benefit estimations, guide them through a series of N-of-1 randomized crossover trials to choose the best diet or exercise to control their LDL and blood pressure and weight, and really engage them in a process over time that looks to see what somebody can achieve without medicines, and then recalculates what their remaining lifetime risk is to give them the right dose of the right medicine at the right time, and really put the patient at the center of that whole process early in life, and equip them with both the incentives and the rewards and the tools to effectively manage their own health over time.
Thank you very much. That was a clear answer and a strategy that hopefully our colleagues going to work on it. Dr. Kharabsha,
Yes.
what would you do?
Yes, I actually, this is actually a wonderful program as they started. But a couple of things which we need to talk about is that first, we just now we have to make sure that people agree and people are convinced that, you know, LDL reduction will help the population, because we're having a lot of skepticals, Waleed. Some people are there saying this is not or not. So I think education will be the first thing, that we have to educate the primary care physicians, internists, cardiologists, you know, and show them the data. Then I will have, you know, as we said, we have very good armamentarium. We have all the weapons available, but we have to use them in the right thing, you know, or in the right way. And then after that, I make sure that it's all accessible. Everybody's aware that this is, you know, a that it's a program of national interest, that it will help, you know, people live longer, it will reduce event rates, it will reduce the cost. Then I will make sure that, as we say, as Dr. Ferenc mentioned, that, you know, that people, to encourage them to use it. And then you go to the last stage where you really will only, as they did in the United States and the actual United Kingdom, that reimbursement is per outcome. I will, you know, go test, look, and make sure if your patient is not achieving his LDL goal, you will not be reimbursed. So I think you have to go through, however, I don't penalize when I don't provide them with the right therapy. I don't penalize when I don't make sure that they're educated and they have all the data. So I will go through 1, 2, 3, then you go for the sort of being more firm. But I think this is definitely of national interest, and I think it should be applied to in every country, especially we do have the resources for it in Saudi Arabia. Thank you.
Gotcha. We really need to develop a working group that can try to do what the UK did at the NHS level, that trying to address that. That's what the Saudi Health really proactive about it. My next question, Professor Ferenc and Dr. Kharabsha, you talked about risk stratification. Before that is identification of the population at risk. And what do you think, especially in Saudi Arabia, as you know, that we have an earlier age and a larger, based on Dr. Habib study that did a lot of familial hyperlipidemia in the population. What do you recommend the screening age if you have the power to implement it.
I would suggest that there really is no right age for that. If somebody has homozygous familial hypercholesterolemia, then you have to do it as early as possible, maybe at birth, maybe within cascade screening within known families that have familial hypercholesterolemia. For everybody else, though, I think sometime in childhood or young adulthood, my own view is that we can probably begin to, if we have modest, sustained reductions over prolonged periods of time, that really is the key. And so there really isn't a lot of need to sort of begin to interfere with childhood, for example. We can begin in the teen years or early adulthood to begin to address exactly who's having risk. But what's really important to recognize, particularly in Saudi Arabia, but everywhere else in the world, is that LDL in particular, but blood pressure in addition, has certain kind of characteristic trajectories. It rises between ages of 20 and say 50 in men, plateaus, and then falls later in life. In women, it begins to rise slightly later, rises more steeply, plateaus in the 60s, and then falls. So it's important not to be fooled by a low level early in life, because the natural history of that is that it will rise over time. And the best way, everybody has their individual trajectories. So the best way may be, the most informative way to personalize both estimates of risk and potential benefit would be to measure serially every 5 years or so, beginning early in life, what each person's LDL and blood pressure is, and then to plot that, to get somebody's individual trajectory and use that information to personalize their estimates of risk and benefit and give them actionable information that's very personal and specific to that person.
Thank you very much. That's really helpful. Dr. Kharabsha, what's your thoughts?
Yeah, actually, this is very, very important question, Walid. And I think, yes, and we know families now, the familial homozygous, you know, the families, of course, you have to screen early. Those familial homozygous, you have to screen early. However, for the general population, I still agree we have to, sort of start at around maybe 18, 20. As we showed in those, trials, like if you start even, that late, if you want to call it late, 20, still you will be able to reduce the risk significantly. You are reaching about 75% as the curves shown by Dr. Ferenc. However, as I mentioned, certain families, certain people might need to be screened early. Second is, in our population, is the education. I think it's also the eating habits, the exercise, the weight issues are very important. It has to be started, the education in school. I think that's very, very important to start with that. But, screening for cholesterol and considering therapy still has to be delayed a little bit.
May I say something? I agree with that. I thought it's such a powerful message. I would say that the way most people respond is not by scaring them about what their risk is, but by empowering them with how much they can benefit from specific actions, and really sort of saying, look, we can, just with education and explaining intuitively the biology of disease, you can eliminate your lifetime risk of cardiovascular disease. You can control your destiny and never have hypertension or diabetes or heart attack or stroke. And this is what, and you can choose to do that. And this is how you can do it. And then to put together systems that empower people to begin to want to invest in their own health or invest in their own arteries, and really empower them about how much they can benefit from specific actions. I think a positive, uplifting message is much more effective than a scary message or something that sort of penalizes. Reward people for healthy behavior, even at a government level, tax breaks or cinema tickets or train tickets. If somebody can meet their goals, reward them. And then in the end, you prevent events and reduce the cost of hospitalizations and expensive third and fourth medicine. So I think we have to empower people and lift them up and to really understand how much they can benefit from specific actions.
Very crucial point. I agree with you. This population communication strategy it's really have to be calculated, as you mentioned. Totally agree. There's a question from the audience by Ibrahim saying, any role for smoking and alcohol use or diet and exercise and LDL reduction efforts?
Well, it's, if I may answer, I'm terribly sorry.
Yeah, go ahead.
I'm
Go ahead.
sorry. No, please. Okay.
No, go ahead. I was just at the end. I did not hear for the risk reduction. They're saying.
Yes, so any role for smoking, alcohol use, or diet and exercise in LDL reduction.
In LDL reduction, surprisingly, exercise has very little effect on LDL and ApoB-containing lipoproteins more generally. It can reduce triglycerides a little bit by weight loss, but it doesn't generally translate into a number of ApoB-containing lipoproteins or LDL decreases. By contrast, diet can be important. The problem is, of course, everybody responds to diet differently. And that's really why something important like a longitudinal health management platform that's digital and accessible by everyone becomes extraordinarily important. A 600,000 person trial will begin soon, where people will have free access to a prospective health management platform, and they will be able to go on that platform and be walked through a series of N of 1 randomized crossover trials to help them choose the best diet that reduces their LDL or their blood pressure or their weight the most, and then go over a washout period, be re-randomized to a different type of diet. And they can begin to identify precisely which diet works best for that individual person, which will be not simply the one that the guidelines recommend, but what works best for that person to lower their LDL the most, or their blood pressure or their weight that they could adhere to. So that combination of raising lifestyle recommendations to a science with randomized N of 1 crossover trials on a platform that's freely available to everybody is another way to empower people to take charge of their medical destinies.
Look forward for the trial.
Well, yeah, sorry, Waleed, if you allow me. This is a very important question, by the way, that as we showed, or the curve, if you look at the curves of the, the atherogenesis with the LDL levels, that if you have, let's say, diabetes, your atherogenesis starts at a much lower LDL levels. But if you have, let's say, diabetes, established coronary disease, it even starts even at lower. So it's the milieu which is there. It's important. What I'm trying to say also is that exercise reduced your event rates for those people who had a heart attack just by exercising, regardless of the LDL. As Dr. Ferenc said, exercise is a very modest reduction in LDL. So don't look for that. However, regardless of that, it will reduce the chance of having another heart event by almost 40%, like aspirin. This is very important. So we're not trying to say focus only LDL. There's so many other things. Also, very important thing. People, we could achieve a very low LDL level while we are not dieting. We could now, with our very potent, you could give high dose intense statin and PCSK9, and the LDL will go down to 30, but you're eating junk. There is also a study which looked at that. The people who diet and take their medication, they did much better and much lower event rates. So it's very important that we followed our diet and exercise regardless of the LDL. We have to attack, as we said, we have never reached the zero. We always have this. That's why we were talking about unmet needs or the residual risk. That's why we added this. We studied the VASIPA, or So we're trying to reduce that risk to zero. So you need to add all of that to reduce your risk, not only by LDL. I hope that shed some lights on that.
I agree completely. I think that was a fantastic summary.
Thank you very much. There's a question about ketogenic diet effect on LDL level.
It can vary. So sometimes some people have actually a reduced LDL and ApoB level. Some people have, just like a low carbohydrate, ultra low carbohydrate diet, paradoxically, you can get an increase in LDL or ApoB particles for some people. It really is variable. And the only way to know, unfortunately, is to experiment. Now, importantly, I agree completely. It's not just about LDL. If you can reduce whatever diet you're using, it reduces your weight, because what will emerge soon is that diabetes can be completely prevented and reversed. And the reason for that is diabetes is caused by an increase in hemoglobin A1C in response to weight gain. But that increase in A1C in response to an increment of weight gain is different for each person, which means that we can begin to plot how much A1C increases in response to weight gain to identify each person's personal weight threshold. And importantly, the effect of increased hemoglobin A1C caused by weight gain is not cumulative. Unlike the irreversible structural injury to the artery wall caused by LDL or blood pressure, the effect of weight on dysglycemia is a perfectly reversible metabolic change, which means we can predict each person's personal weight threshold. If they stay below that weight threshold with whatever diet or exercise program they choose, they will never develop diabetes. And if they do develop diabetes, if they lose enough weight to go below their personal weight threshold, they can reverse diabetes. And the best way to protect the artery wall in somebody with diabetes is to prevent the diabetes or reverse it, to protect the artery wall while also lowering LDL. So I think there's there's lots of really exciting developments coming on. It's all about reducing cumulative injury to the artery wall. LDL is the cause of the atherosclerosis, but there's other forms of injury to the artery wall that we also have to be very careful about.
Such an exciting advancements really we're witnessing in this decade. I have a question about the population study that was published last year in JAMA by Zeng and his colleagues, where they took about, I believe, 18,000. They follow up for 2 decades for multiple cohort studies. Surprisingly, they found that there is correlation with coronary heart disease risk reduction, but was not translated with cerebrovascular stroke or heart failure. What do you think the rationale? What do you think probable? Why it's not was not found in the population that LDL is correlated with cerebrovascular disease?
If I may answer that, I'm terribly sorry to answer all the questions. I don't mean to overspeak. I apologize if I'm speaking too much. But if I may answer that, because it's a really important point. LDL in randomized trials, LDL, a millimole of lower LDL reduces the risk of stroke by almost the same amount as it does reduce the risk of heart attack and acute coronary events. That's not the case in observational research. And the reason for that is that in observational research, where we have much less rigorous follow-up and adjudication of events, 1/2 of those events that are described or classified as ischemic stroke are actually thromboembolic events from left atrial appendage thrombi and atrial fibrillation. And for that reason, that biases the results towards the null and fools people into thinking that observationally, LDL is not associated with stroke. If one adjudicates those events carefully, there isn't any question that lowering LDL or ApoB-containing lipoproteins more generally clearly reduces the risk of stroke in the PCSK9 trials, in the statin trials, in the ezetimibe trials, in all of the trials, and even in the Mendelian randomization studies, if we characterize and classify the strokes properly and eliminate thromboembolic events from left atrial appendages.
Thank you very much. This is a frequent question we get asked, but I really appreciate that succinctly. Any final words, Dr. Kharabsha?
I think that he said it, Professor Ferenc said it very well. We should be very careful interpreting observational studies. We have many, the vitamin D, you have to really be very careful. The selection of the patient, selection of events. This is very, very important. You really need to, whenever you see that, you have to confirm it or disprove it with a randomized trial.
Thank you very much. I think it's really, it's just a joy to talk to both of you and learn from you. I believe the audience the same. They had a great time. I really appreciate for being here, and I wish you all a lovely night. Thank you very much.
It was a real pleasure and an honor to be here. So thank you very much for inviting me. Fantastic questions and discussions. Always so grateful to participate with such a thoughtful group. So thank you very much.